Hello, I am Siu-Hin. I am the Director of Heart Failure at United Hospital, part of Allina Health, Minneapolis Heart Institute in St. Paul, Minnesota. I'm very excited to be all of you today to talk about heart failure. And the topic of my presentation today is Heart and Hope Thriving with Heart Failure. One of the major things I hear from patients that we see every day is that heart failure is a horrible term, right? It really doesn't have a lot of optimism. Today, I'd like to talk about how we can transform heart failure into success and living, not only living, but thriving with heart failure. I have no disclosures. And so there are three main objectives for today. First, I'd like to talk about what heart failure is, how we in cardiology think about heart failure, and how does one know if they have heart failure. Second, we want to talk about once someone is diagnosed with heart failure, how to live a fulfilling life. There is no cure for heart failure, but there are many tools, including medications and devices nowadays that we have to allow us to treat patients with heart failure and for patients to live a very fulfilling life. And finally, I'd like to talk about what the future of heart failure looks like. Again, the term heart failure is very depressing, can be very depressing. And I'd like to talk about all the possibilities and all the research that's going on, a lot of it at Minneapolis Heart Institute. How we can really transform heart failure into success. So, starting off with the definition of heart failure, there are many definitions out there, and there are many different ways to think about heart failure. My favorite way to think about heart failure is think of it as a mismatch between supply and demand of oxygen for the body's different organs. So, heart failure basically is the heart not working very efficiently. The heart is unable to meet the demands of oxygen from the body. It's not able to pump enough blood. It is really a supply and demand mismatch. And because the heart is not functioning efficiently, what happens is that blood, or what we refer to as fluid, gets congested and it backs up. When the pump doesn't work, fluid backs up behind it. If it backs up in the lungs, it causes a lot of shortness of breath. If it backs up in the legs or in the abdomen, it causes a lot of swelling. There are two main types of heart failure in terms of how we classify it. This is important because it also affects how we think about treating the different types of heart failure. But there's basically heart failure where there's an inability to pump well, an inability to squeeze well. And there's heart failure where there's an inability to relax or fill. So we refer to those as systolic dysfunction. Oftentimes you hear the term ejection fraction. That's a measure of how well the heart pumps. So systolic dysfunction, heart failure with reduced ejection fraction is when the heart is not able to squeeze very well. And then there's the diastolic dysfunction or stiff heart, where the heart is not able to relax very well. As you can see from the diagram, in order for a pump to work, it needs to squeeze and relax to fill with blood, squeeze again, relax. Here is a diagram of a heart, basically showing the squeezing and the relaxation and how important it is for the muscle to work well. Now, as you can see from this diagram, there are also many other components, such as valves. There are four main valves of the heart. So these valves are dysfunctional. It can also cause the heart not to work as efficiently. So valvular heart disease can cause heart failure. A heart attack that damages the muscle and affects the ability of the heart muscle to pump, that can affect the efficiency of the heart and lead to heart failure. So we'll talk about that in terms of the risk factors to watch out for and how to manage once someone has heart failure. But you can see the heart is a really complex organ, and really many things can go wrong to cause heart failure and subsequent heart failure symptoms. So this is one way that I like to think about heart failure when we see patients in clinic or in the hospital. First, we diagnose someone with heart failure. And we'll talk in a bit about how we do that and what sort of studies, labs, information, etc. we use to diagnose a patient with heart failure. Then we try to figure out the cause of the heart failure. That's the etiology. The cause of the heart failure also affects the severity, the prognosis, and the treatment or the management. So it's important to stage heart failure to figure out how bad it is. We'll get to the diagram below in a second. And then prognosis would be the outcomes, an estimate of how the outcomes are, whether that be symptoms, life expectancy, etc. And then finally, management, and that includes medications and also devices. So when we talk about severity, I'm going to go back to this box right here. Severity, determining the severity of heart failure is very important because it really, really affects the treatment and it affects the prognosis. So one of the ways that the American College of Cardiology and the American Heart Association determines staging for heart failure or severity of heart failure is based on whether or not there are symptoms, first of all. So if there are symptoms, it's stage C and D heart failure. However, the idea of creating stage A and stage B, or these are asymptomatic patients with heart failure, is understanding that there is a progression. And it's important to identify patients early. And you can see the survival here. So patients do very well in stage A and B heart failure. But once they reach symptoms, symptomatic heart failure, when the body is not able to compensate for that inefficiency of the heart, the outcome, the survival outcome declines drastically. Right? And you can see on the x-axis here, it's 5 years of this marked decrease in the survival, depending on the type of heart failure and so forth. But it's the outcomes are very poor. Whereas here, the duration may be extended. It might be months, it might be years, it might be decades if we're able to treat these risk factors well and prevent progression from stage A to B to C and D. So what are some of these risk factors that we think about? And we'll revisit these again and again, but this helps us in thinking about diagnosing someone with heart failure. We think about someone's age, whether or not they have coronary artery disease or blockages. These are the same things we think about in heart attacks. Hypertension or high blood pressure, high cholesterol, diabetes, peripheral vascular disease, and metabolic syndrome, which encompasses diabetes. These are the risk factors of symptomatic heart failure development. So someone may have a lot of these, but they may not have symptoms yet, and they wouldn't be in stage C or D. But we want to try and do everything possible to prevent this progression, right? Patients can also have non-cardiac risk factors. So the body works together and effects on the heart can affect other organs as well. So there's renal dysfunction, anemia, lung disease. All of these lead patients to be more likely to develop symptoms than if there's just cardiac risk factors alone. These are some of the symptoms to watch out for. So heart failure at the end of the day is a clinical diagnosis. So we can obtain all the labs, we can obtain all the imaging. At the end of the day, what we're trying to do is to determine how patients are feeling and also with their physical examination. A lot of the things we talked about in terms of symptoms like swelling, shortness of breath, we can also determine on examination. We can hear when there are crackles in the lungs, which represent fluid in the lungs, or we can feel that there is a lot of pitting edema or swelling in the legs. Those are signs and symptoms of heart failure. So these are the things to watch out for. If you have these symptoms, it may be a sign that there is heart failure. So coughing, shortness of breath, these relate to fluid buildup in the lungs. Swelling of the legs, the abdomen, this reflects fluid buildup in the peripheral extremities and the rest of the body. Weight gain, so notice it's a sudden weight gain, okay? Long-term weight changes may be from caloric weight, might be from eating, might be from intentional weight loss. However, sudden weight gains are generally from water. There isn't really a reason why someone should gain 2 to 3 pounds or 5 pounds in a 24-hour period, aside from water buildup. That's really the only thing that can change that fast. So that's why one of the best surrogates we have of fluid buildup is weight gain. So we counsel our patients to monitor their weights very closely every day. And if there's a sudden weight gain, then that might be because of fluid buildup and worsening heart failure. Usually there is a trigger of some sort. It might be because medications were missed or medication non-compliance. It might be because of someone went to a party and ate a lot of salt and drank a lot of water. So dietary non-compliance. Those are probably the two most common reasons why people develop acute heart failure and sudden fluid buildup. If we know about it early, we can treat them because patients can take more medications to try and get rid of the fluid. But the trick is to really, really identify early because once it spirals into more and more fluid buildup, it becomes exceedingly hard to actually get rid of the fluid. Other symptoms, dizziness. Some patients may have chest pain, loss of appetite, trouble sleeping. This is a nice picture that kind of shows a typical heart failure patient. Might be clutching their chest, sitting on the edge of a bed. They have difficulty laying flat because when patients lay flat, the fluid layers in the lungs and causes a lot of shortness of breath, swollen legs, fluid in the lungs, fluid in the abdomen. So this is a typical picture of someone with heart failure. In terms of prognosis, so once someone is diagnosed with heart failure, this is a typical curve of the prognosis or the outcomes of heart failure, right? So when we talk about heart failure prevention, there's a period generally without symptoms and patients do great, right? They're in excellent physical function. But then usually it gets to a point when there's a heart failure exacerbation or what we call acute heart failure, right? And there's a decline. Right? Patients get admitted to the hospital, they get better. When they're discharged from the hospital, they feel better. Maybe not quite as good as originally when they were in excellent condition, but much better. And then they do well for a while, do well for a while, and then another decline. See, so it's a kind of a staircase type graph in terms of heart failure outcome. So the biggest thing we can do is really prevent patients from needing to go to the hospital. If we prevent the big declines, right, the outcomes are much better. So this is a kind of a shape of the curve to remember for heart failure. It's really kind of like a staircase type pattern, and we really want to prevent hospitalizations, which are these big declines. What are the causes of heart failure? We've mentioned this a bit already. There are two main types of heart failure, either the heart not squeezing very well or not relaxing very well. But these are the major things we think about in terms of risk factors. And you can see the relative risk numbers over here. So one of the biggest risk factors in the United States by far, the biggest cause of heart failure is coronary heart disease. These are cholesterol plaque buildup in the arteries that supply blood to the heart. It's the same thing that causes heart attacks. Coronary heart disease leads to myocardial infarctions or heart attacks. So by treating that, right, it really helps reduce the risk of progression and the development and progression of heart failure and symptoms. Um, what happens is when there's lack of blood flow to a part of the heart muscle, it dies. It's not able to pump very well, and that leads to heart failure. Diabetes, you can see how high a risk that is. Valvular heart disease, we talked about that already. But when the valves are not working well, the heart is not pumping efficiently. Smoking. So one of the overall most important things in terms of risk reduction would be smoking cessation. Aside from heart failure, it will reduce heart failure, it will reduce heart attacks, it will reduce strokes, it will reduce peripheral vascular disease, it will reduce lung cancer. So one of the biggest things anyone can do if they're smoking is to really quit smoking, not only for heart failure, but really for overall health. It's a single thing that can improve someone's health the most. Um, Very, very, very important to think about. High blood pressure is certainly very important. To treat high blood pressure is a silent killer because we don't think about it, and patients generally feel fine, even if they have high blood pressure, and obesity. So this diagram on the right kind of organizes this into the different categories of things that lead to heart failure. And then things that are preventable and things that are maybe not so preventable. So lifestyle, a lot of these things are preventable, right? And things to focus on, right? And high blood pressure, And then also other things, right? Other organs, lung problems can cause symptoms. So this is kind of a nice diagram showing the different causes of heart failure. Heart failure is very, very prevalent. There are over 6 million adults in the United States with heart failure. This is a map showing heart failure mortality rates um, in adults. And you can see it's really prevalent everywhere, but particularly affects kind of the southeast part of the United States. We're here in Minnesota. You can see it disproportionately affects a lot of rural communities as well. So it's really important to think about um, the national, regional distribution of heart failure. And from our standpoint, from a healthcare delivery standpoint, we think about how we can improve outcomes really for everyone across our communities. Heart failure very much is associated with age. Risk increases with age. That is a non-modifiable risk factor. Obviously, we cannot change that, but we can be aware of it. And also, it's one of the leading causes, as I'm sure many of you know, leading causes of death in the United States. The emphasis should be on early detection and treating pre-existing conditions. So we talked about this earlier about the diagnosis of heart failure. How do we diagnose heart failure? Well, we talked about the symptoms. So one of the most important aspects is listening to the story, understanding the risk factors, and physical examination consistent with fluid buildup. There's lab work that we can do. We check kidney function, potassium. We check this B-type natriuretic peptide, or BNP, which is released when the heart muscle is stretched. And therefore, that is a marker of heart failure. And also imaging or echocardiography. Echocardiography is basically ultrasound of the heart, and it's one of the most common tests that we use to identify many different heart issues. We use it to identify valve disease. We use it to identify blockages if there are asymmetric contraction of the heart. But it can't diagnose heart failure, but it can really suggest heart failure and can classify and determine the etiologies of heart failure based on just simple ultrasound pictures of the heart. There are also other rare causes of heart failure. So there are many genetic causes. That's probably one of our least well understood cause of heart failure. Could be inflammation. In the time of COVID, there was quite a bit of COVID myocarditis based on infection. It causes a lot of inflammation. Infiltrative diseases such as amyloidosis and sarcoidosis. Pregnancy, leads to many normal physiologic changes of the heart, but there could also be abnormal or exaggerated changes that lead to heart failure. Things like HIV, connective tissue disease, substance abuse, chemotherapy are other common causes of heart failure that we see. So, when someone is diagnosed with heart failure, how does one live well and live a fulfilling life and prevent heart failure from getting worse or progressing? Well, one of the really important parts is to eat a healthy diet that includes the standard cardiac recommendations of a Mediterranean diet, fruits and vegetables, fiber, low sugar, and omega-3 fatty acids. But in addition, to prevent fluid buildup, really to limit salt intake, which oftentimes lead to a lot of fluid buildup, as well as being compliant with medications and limiting fluid intake. General recommendations are 2 liters of fluid per day and less than 2 grams of salt. Exceedingly difficult to actually achieve, but very important in terms of preventing fluid buildup and acute heart failure. Tobacco cessation, we have talked at length already about and why that's important. Physical activity and doing aerobic exercises, controlling hypertension and other risk factors, including high cholesterol, weight loss, and treating diabetes. What are the medications that we use? So once we've identified someone with heart failure, we classify them into reduced ejection fraction, or the systolic heart failure, when the heart is not pumping well or squeezing well, or diastolic dysfunction, heart failure is preserved ejection fraction when the heart is stiff and not relaxing well. For the purposes here, we'll focus on reduced ejection fraction. There are more medications and tools for that type of heart failure. But basically, we separate it into 2 categories. First, we try to improve outcomes. We help patients live longer, right? And there are really 4 main categories of medications to help with that. They're beta blockers, so they include medications like metoprolol and carvedilol. ACE inhibitors, angiotensin receptor blockers, and the newer medication, Entresto or valsartan sacubitril. These are medications like lisinopril, losartan, valsartan. These also help the heart pumping function and improve outcomes. Spironolactone, which is a mineralocorticoid receptor antagonist, that helps there's a mild diuretic, so it actually helps a little bit with fluid, but also improves outcomes and improves symptoms. And then the one of the newer classes of medications, SGLT2s. These were initially developed as diabetes medication, but they were subsequently found to be very beneficial for heart failure, independent of diabetes status. These medications generally end in Flozin. So there are several out there, but they end in Flozin, such as the dapagliflozin. And then, so that is the first category of medications, is to improve outcomes, help patients live longer. Second category of medications are to help patients feel better, right? So these would be medications like diuretics, the most common being Lasix or furosemide. Also, torsemide is a very nice medication that is better absorbed by the body. These really help get rid of fluid and improve the congestion symptoms, improve shortness of breath, improve swelling in the legs. We try to use as much of these medications to improve outcome as possible. So we call it up titration of guideline-directed medical therapy. And we try to use the minimum amount of these medications to improve symptoms that we can get away with, because medications like Lasix, even though they help symptoms and are very important, don't help people live longer. They don't improve outcomes. So that's why we try to use, so the concept is we use the maximum of these in the first category that patients can tolerate without getting side effects. And we use the minimum necessary in order to treat necessary symptoms for the second category. All right, so we are nearing the end. Towards the end, I would like to talk about the future of heart failure and all these potential devices and research that's going on. I think there are several categories of optimism, why we're optimistic in the heart failure realm. First, there are more and more devices that are being developed. So cardiac resynchronization device is a pacemaker-like device that synchronizes the left and right side of the heart. So one of the things that happen in heart failure is that the right or left side might pump earlier than the other side of the heart. So CRT, by synchronizing the two sides, actually can improve symptoms and improve the ejection fraction and improve outcomes. So that is one, and this is all in the category of devices. There are many cardiac devices, there are many in research, many have been approved. Remote monitoring devices, these remotely send information about someone's fluid status. So rather than daily weights, these allow for monitoring of fluid remotely. And they're very effective and very accurate. So they can be very effective. Things that help with valves. So for example, MitraClip and other devices to help fix the underlying causes. So if valve is a problem, then MitraClip will fix leaky valves. That will also help someone's symptoms. And then for end-stage heart failure, there are really three main categories. So these are when medications have failed to really improve the outcomes. The heart is not pumping very well. The ejection fraction is severely reduced. The heart is very dilated. Then options are generally heart transplant, a mechanical pump, which we call VAD or ventricular assist device. This is a device that's surgically implanted in the heart to assist with the pumping of the blood. And then inotropes are medications that basically force the heart to pump harder. The downside is they don't necessarily improve outcomes or improve survival, but they do help symptoms. There are many other ongoing research. Another couple of things that I would highlight is one, we are now better at classifying different types of heart failure. So in the past, we thought heart failure was a very homogeneous population. What we found is heart failure is actually a very heterogeneous population with many different causes, things such as infiltrative, cardiomyopathies like amyloidosis or sarcoid, or things like hypertrophic cardiomyopathy, things like genetic cardiomyopathies. So the better we understand these unique and specific types of heart failure, the better we are able to triage patients to the appropriate treatments. And there are many ongoing research trials on treatments for these specific types of heart failure. So I think that is a very area of a lot of optimism. The other part is genetics. I think traditionally we have lumped genetics all together. even though we know that's a huge cause of heart failure, but we haven't really been able to understand it. Now, with technology, we've been able to identify more and more genes that are associated with heart failure, and we're better at prognosticating, we're better at understanding what the heart failure is from and how to treat heart failure. And we're also better at identifying risk factors in family members as well for genetic cardiomyopathy. So I think that is a also huge area of a lot of research, a lot of opportunities, and a lot of really optimism in that area. So to summarize, today we talked about what heart failure is, a supply and demand mismatch, and an inability to pump blood and deliver oxygen to organs that need it. We talked about the symptoms of heart failure. Remember that diagram. Fluid buildup in the lungs causes shortness of breath. Fluid buildup in the legs causes swelling. We talked about living a fulfilling life, the lifestyle modifications, treating risk factors, and the medications, like diuretic medications, to really help get rid of fluid and control the heart failure. We want to keep the heart failure on a plateau without those large stepwise declines. And then we talked about the optimism of the future of heart failure. A lot of research going on. We better understand heart failure, which allows us to better classify it and give patients the appropriate treatments. There's more and more research on both medications and devices to help manage symptoms of heart failure and to improve outcomes and life expectancy. So we can truly transform heart failure into success. So with that, thank you very much. This is my email and contact information. And some final words that I think it's really important to recognize what heart failure is. It is extremely prevalent. So it's important to recognize it in yourself, in your loved ones, your family, your friends. Identify it early, be able to understand it, be involved in the management of it. And I think there's a lot of optimism with a lot of research in heart failure. So thank you again.
Okay, well, thank you, Dr. Wan, for your time and expertise during today's On the Pulse session. Fantastic presentation. And hello, everyone. My name is John Rickert. I'm the Digital Education Program Manager here at the Minneapolis Heart Institute Foundation, and we'll just be jumping on here to help facilitate the Q&A portion. So the questions that we have prepared today were all submitted prior via the registration process. So a big thank you to our registrants who did submit a question, but please also feel free to add additional questions using the Q&A pod, which is located at the bottom of your Zoom screen, as these may be addressed in future On the Pulse sessions. So, Dr. Wan, the first question that we have from the audience is, how can I monitor my heart failure symptoms at home?
Yeah, first of all, thank you to all the people who submitted questions. I'm very excited because that means people are really interested and passionate about this topic. So I look forward to going over many of these questions. John, the first question you asked is how someone can monitor their heart failure symptoms at home. This continues to be one of the biggest challenges within heart failure. It is hard to determine how bad someone's symptoms are, right? And really the best way we have currently, the best recommendation I have is to monitor weights. Because weight, as I mentioned in the presentation, those acute changes in weight within a day or two generally is due to fluid more so than caloric changes or muscle or fat or any of those changes. Nowadays, there are more devices available to directly measure pressures inside the heart that can give us a good surrogate of the severity of the fluid buildup and the heart failure symptoms. But also keep in mind that the biggest symptoms are shortness of breath and swelling in the legs. So that's why we focus on shortness of breath, swelling in the legs, and daily weights to make sure they're stable within about 3 to 5 pounds.
Thank you very much for that. And along those similar lines, the next audience submitted question that we have is, what should I do if my heart failure symptoms worsen?
Yeah, so that is a great question. And what we encourage our patients is the first thing to do is really to contact your healthcare provider because there are many things. Usually, heart failure doesn't acute heart failure doesn't happen overnight. It's usually not one day that sends someone into the hospital. It's usually been going on for a while, either days or weeks, right? So there are many opportunities to identify problems early, right? So if you contact your healthcare provider, and a lot of times these are provided in the instructions, either from clinic or from the hospital, if your weight goes up by 3 pounds or 5 pounds over a certain period of time, call your healthcare provider and ask about the medications, because the way we treat it is with increasing the dose of the water medication, or the diuretic medications, such as Lasix or torsemide. If we're able to do that early, we can reverse the course and get the weight and fluid balance back down to normal. If we wait too late, the pills are no longer absorbed in the gut. It doesn't work. Patients need IV medications to get rid of the fluid, and then they end up in the hospital.
Thank you very much for that. And I'm going to jump ahead here a little bit since you mentioned medications. One question that we did have from our audience was, what are the side effects or long-term risks associated with heart failure medications, such as a beta blocker, an ACE inhibitor, or a diuretic?
Yeah, that's an excellent question. And that's a question we get a lot in our clinic. Patients do understand what they're getting themselves into when they take a lot of these medications. There are a lot of heart failure medications. So first of all, kind of breaking it down to two parts. So with regards to the symptom management, so that's generally the diuretics, Lasix or furosemide being our most common one. The biggest thing generally to watch out for is the lowering of blood pressure, because the diuretics cause increased urination and people lose fluid, their blood pressure tends to drop. In fact, we use diuretics as a form of pure hypertension treatment. That's what we use it for, is to get the blood pressure lower. So one of the limiting factors is someone's blood pressure is already low to begin with. Then by taking this medication, they can get lightheadedness, dizziness, basically all the symptoms associated with low blood pressure. So one of the ways to prevent that is to measure your blood pressure at home and make sure it is stable and not too low. It's, people ask about a number. I say generally less than 100 on the top number for the systolic blood pressure is on the lower side, but everyone's different. Some people run in the 90s and they feel completely no symptoms, and that's absolutely fine too. So it does vary from person to person. The other types of medications, so the heart failure medications, the four classes. So we have the beta blockers, the ACE inhibitors, the ARBs, the MRAs, the spironolactone, and the SGLT2s. Each of them do have class-specific types of side effects. I would say in general, most or all of them do lower blood pressure a bit, so you can get the same side effect as a diuretic, which would be lightheadedness, dizziness. So we want to make sure patients don't fall because they're dizzy. We want to make sure patients are not extremely tired. Some of these medications can cause some fatigue because they also lower blood pressure, particularly the beta blockers. And then the other big component of side effects to these medications would be kidney function, because particularly the ACE inhibitors, the spironolactone, those can worsen renal function in the short term. So they want to make a distinction. In the long term, they actually improve renal function, but in the short term, when they're first started or up titrated, it could actually lead to worsening kidney function. So that's why in the hospital, we often do daily labs is to check kidney function while we're starting or up titrating these medications. But that is something to certainly be aware of. And oftentimes, if it's in the clinic, we check kidney function a week or two after these medications are started or up titrated. So those are the main things to watch out for in terms of side effects.
Yeah, and thank you very much for that. And so you mentioned kidneys. This attendee had asked a general question of, will heart failure affect other parts of my body, such as the kidneys or lungs? Or they go on to say, or other conditions that I have. If you could speak to that, that would be great.
Yeah, absolutely. So we talked about heart failure really being kind of involved with multiple other organs, right? It's the inability to deliver blood to other organs. So two of the most common organs that are affected are the kidneys and the lungs. In fact, there are terms for this. There is cardiorenal syndrome and there's cardiopulmonary syndrome, right? There's basically the interaction between the heart and the kidneys and or the heart and the lungs. And the idea here is when one organ isn't functioning very well, the other organ also suffers. And it could be the other way around. If the kidneys are not functioning well, that can also affect the function of the heart. So I think the big concept here is that when there is heart failure, it is important to also check the other organs, check the kidney function, check the liver function, check the pulmonary function, because it's really in combination of all of these, when everything is dysfunctional, that's when the worst outcomes happen, and that's when the most symptoms occur. So absolutely, heart failure can affect every single part of the body. It's important to understand. It can also help us diagnose why, for example, there's certain organs that group together. It might be a syndrome or a pattern, but it affects our diagnosis, it affects our management, it affects our prognosis. So it's really, really, really important to check all the other organs that are associated and are affecting the heart failure.
Yeah, absolutely. And thank you very much for that insight. So let's talk technology for a little bit here. So this attendee asked, what role has technology played in the evolution of treating heart failure? And I would just add to that, is there any technology that's in the works, so to speak, currently that you're excited about?
Yeah, so in the past, even before, so I mean the stuff like beta blockers and ACE inhibitors, they've been around for decades now. But there was a time, even before these medications, all we had were really water medications to get rid of fluid, and then a kind of an old medication called digoxin, which was initially thought to, manage atrial fibrillation. It also helps the heart pump a little bit harder, improve symptoms and so forth. So all of these things that we take for granted nowadays have actually been continual developments and technological developments. I would say the first revolution um, was changing the mindset from purely symptom treatment, which is getting rid of fluid. So that was probably the first part way back when, was treating symptoms. But it was a mindset shift in mindset from treating symptoms alone to not only treating symptoms, but also improving outcomes and improving life expectancy and reducing hospitalization. That's the advent of the four medications, the beta blockers, ACE inhibitors, and ARBs, spironolactone, and SGLT2s. Then after that, kind of the next, revolution in terms of thinking was that not only can we treat with medications, but we can also treat with different types of devices, right? So this was the age of things like, pacemakers, defibrillators. Defibrillators we use to prevent sudden death in patients with really low heart failure because we know it's associated with that. Um, and then CRTs, things like a resynchronization device to help the heart synchronize and pump better. So then there are all these different types of devices, and ongoing, there continue to be a lot of devices for different stages of heart failure, whether it be monitoring devices to get a better assessment of the fluid status that's built up, or devices to modulate, certain aspects of heart failure to improve outcomes. Right. So I think it's really, there are many technological advancements and developments. The last development is really with the most recent development is with all the advanced heart failure management. So things like heart transplant, as our transplant immunology understanding it have improved. Our mechanical pumps, our LVADs have improved. There have been different generations of those. So those are our most advanced technologies right now to really help really bad end stage heart failure. But I think that's how I like to think about the technological developments in heart failure, is that there's been these revolutions, right? We start with fluid treatment alone, then medications to really help with outcomes. Then we thought about devices. Then it's actually really technologically advanced things, either like a heart transplant or mechanical pumps to really support the heart. So I think that's one of the things that's so exciting about heart failure, is that it's not only about medication and not only about getting rid of the fluid and the congestion. It's all these other things and research and all these other devices and medications that are so promising and really a source of optimism.
Certainly, and thank you very much for that, Dr. Wan. And you mentioned research at the end there, so I think that's a good segue into talking a little bit about research here. So, from your perspective, what excites you most about the future of caring for patients with heart failure? Are there any exciting research studies that have recently been published or will soon be published that you are excited about?
Yeah, absolutely. So I personally am involved in research at the Minneapolis Heart Institute Foundation. I would encourage all of you, if you are interested in research, to go to the Minneapolis Heart Institute Foundation website, which lists a lot of the ongoing trials, research, the accomplishments, really across many different specialties, not just heart failure. but also with devices, with valves. It is such imaging, it's such a environment rich for research. I would say the thing, I mean, there are many things that are exciting, but I'm a little biased. My own personal area of research is cardiac amyloidosis, and also I have an interest in sarcoidosis, the hypertrophic cardiomyopathy. Where does that fit in, right, in the big picture? So the idea is kind of towards the end of my presentation, I really mentioned that there is a paradigm shift where in the past we lumped everyone with heart failure together and we tried to treat them with the same medications, right? And it makes sense because in order to understand whether or not medications work, we need large numbers, right? We need trials with a lot of people, right? So we lump them all together. They have shortness of breath, swelling, they have heart failure, we're going to try the same meds, right? The issue was that a lot of the trials failed. So like when we try and apply the medications for our reduced ejection fraction population to the preserved ejection fraction population, it didn't have the same outcomes. It didn't have the same results. So that's when we started to think about maybe this population is inherently different, right? So the preserved ejection fraction population is not the same as the patient with a heart attack with, heart muscle that's dead and not pumping well, right? It may be because of these unique things, right, that I'm very interested in, like amyloidosis or sarcoidosis or hypertrophic cardiomyopathy. Well, once we identify these unique things, right, then there are unique treatments. So there are, a lot of research studies ongoing to look at specific ways to treat something like amyloidosis, right? There are different mechanisms. Can we stop the production of these abnormal proteins? Can we stop the deposition of it? Can we actually dissolve these abnormal proteins? Things like hypertrophic cardiomyopathy, which fall in a genetic type of cardiomyopathy, are there specific things that we can alter in terms of from a gene standpoint, from a counseling standpoint, that we can do to alter management for a lot of these unique cardiomyopathies. So I think that's where a lot of the research, certainly at the Minneapolis Heart Institute Foundation and a lot of institutions across the country are focused on right now, is really understanding the underlying pathophysiology of what's going on, right? Grouping patients in that, stratifying that, not lumping everyone together, right? And then by understanding the mechanism, really developing new medications or devices or treatment options to target those specific problems. So it's a much more targeted, directed approach. And that is what excites me the most about the future of heart failure research.
Yes, absolutely. And I think that makes a lot of sense. And you had brought up the Minneapolis Heart Institute Foundation and the research that we do here. So I'm happy to add a link to the chat pod that can direct our attendees today to learn more about the research that's taking place here at the Minneapolis Heart Institute Foundation. Um, Before we sign off here, there was a question about, are there any support groups or resources for heart failure patients that you would recommend?
Yeah, absolutely. So there are many different resources, both online and in person. So the national organizations that I would really highlight would be the American Heart Association, the American College of Cardiology, and the Heart Failure Society of America. These are national organizations that really seek to, they have kind of multiple roles. But they seek to, one is provide patients with resources. Know that you're not alone because heart failure is so prevalent, right? So it develops a community out there. They are certainly very much involved in research. So there are more resources, there if you're interested in the latest and cutting edge research out there. They support research, they publish research. A lot of the staging system, that we talk about for prognostication, that was developed by these organizations and content experts across the country, developing these guidelines, right, and what we should be doing. Um, so I think those are certainly one source of resources. Another part would be your local healthcare organization. Here with Minneapolis Heart Institute, we're with Allina Health, and there are many resources within our organization. There are many resources within different local organizations as well, and local healthcare and hospital systems that can provide information and additional support as well. So those are some of the kind of the big organizations or sources where I would reliable sources where I recommend going to, because heart failure is so common, right? It is out there. And this important message is, know that you're not alone. Many people are going through this similar symptoms. And it's important, right, to understand different perspectives and how other people manage their heart failure and how they live with heart failure. So thank you. Yeah, that's a wonderful question.
Yeah, agreed. And thank you very much for providing those resources. So those were the questions that we had prepared for today. Do you have any final words for our audience before we sign off?
Yeah, so I think to reiterate from the presentation, really the big messages I want everyone to take away from this on the pulse, just a couple big messages. Okay, heart failure is very 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 prevalent, so think about it. I think it's oftentimes very under-recognized. Think about it for yourself, your friends, and your family. Heart failure is manageable. I think traditionally it has been a very depressing diagnosis, but I think there is a lot of reasons why we have optimism. And my passion is transforming, patients' perspectives really from one of pessimism and heart failure to thinking about how we succeed, right? Heart success, thinking about the research, thinking about all the tools we have to manage heart failure. And then, finally, I think it's really recognizing that it is a process, right? It is certainly not easy living with heart failure, but with all the research and management options and understanding, I think that's what a lot of us as heart failure providers do, is to really try and help patients understand the condition. That really empowers people to take back control, right, of this condition that they have and live a very, very fulfilling life. So those are kind of the final take-home messages that I want to convey to everyone.
Excellent and very well said. So that's all the time that we have for today, folks. A big thank you again to Dr. Wan for presenting on this excellent topic. And thank you to all of our attendees who joined us this afternoon. We appreciate your participation. Before we sign off, I just wanted to mention that our next On the Pulse session is scheduled for Wednesday, December 18th. And this will feature Gretchen Benson and Susan White, who are both registered dietitian nutritionists. And they're going to be presenting on Nourishing Your Heart, which is a presentation about the ideal diet for cardiovascular health. So, you had mentioned, Dr. Wan, diet as a preventive measure for reducing your risk for heart failure. So this should play in quite nicely with that. So I'll go ahead and add a link to the chat pod now, which you may use to register, and we hope to see you there. So thank you, everyone, and have a great rest of your day.